Okay. So we end up with a multifidus tear. All right, Robert, what do you think of this case?
Okay, here I see some edema within the right paraspinal musculature. I'm not entirely sure what the muscle is, but I'd be concerned for a strain there.
Yeah, intracranial lumborum tear. So there's just muscle tears. Just want to bring these in to remind you that muscle tears can still cause back pain, especially in athletes. And don't forget to look for it. Tayson.
What would you do for that?
Robert.
Yeah, I'd have them take a break from sports and just rest.
Yeah, ice initially to take away the pain and then rest. You certainly wouldn't open it up and try to sew it together, because that'd be the worst thing you can do.
Right. Tayson, what do you think of this case?
All right, so it looks like we have some edema there in the proximal right psoas muscle.
Yeah, and then also in the bone here as well.
Yeah, a little bit in the bone as well.
And here are the sagittal images. This was a psoas strain, and this is probably a little avulsion, I guess, off of its attachment to the spine.
Okay.
Okay. Dan.
So there's, I think that's probably enough.
Be sure and yell at the mic over
yes.
here.
So it's sensitive sequence stir. There's increased signal within the posterior superior aspect about 5, and it's like a curvilinear defect.
Right. And this patient had recent trauma, and this was a stress fracture. So just some other things. Normal or abnormal?
Very abnormal. Yeah, so, moderate aneurysthesis. On the left, is it 4 on a 5?
These are two different people.
Yeah, and then 5 on 1.
Yeah.
Maybe on the right.
Yeah, so spondylolisthesis that you're familiar with. And then you have to look for the facet joints or pars fractures with these, right? Robert.
Okay, so we have a 14-year-old with back pain. Looks like we have a bone scan of some sort. I don't see anything grossly abnormal here, but
Yeah, it's pretty subtle there. Yeah, I agree. It's not grossly abnormal. Maybe in retrospect, there's a little bit of a takeover here, but I think most people probably wouldn't call that in prospect. And here's the MR exam.
so here it looks like there's some marrow edema in the pedicles.
Yeah, in the pedicles there. Right. And here you can see the axial images. You can see a little bit of edema over here. Maybe a little low signal intensity coming across the pedicle in that location. And here's a CT examination.
Yeah, there it looks like there's some sclerosis and maybe a faint fracture line.
And through here.
Yeah.
And that was a little bit, about a few weeks later. Mm-hmm. Right. And then here are the sagittal images of the CT.
Yeah, well, I guess it looks fairly similar. There's some sclerosis and maybe a faint fracture line on that right image. Some spondylolisthesis.
And then here we can see there. And this is kind of close to that. Yeah, we can see through here. Following it up. He was on a brace for 6 weeks and actually got better. Okay, Tayson.
All right, chronic back pain. I do see some degenerative disease, worse at L5, S1. Just a lot of edema in the posterior elements, soft tissues there, right?
I don't know we've got a little bit of sclerosis here, maybe. Here are the axial images at L4. There we're going to L4-5. And then here, right
Yeah, a
there.
lot of sclerosis of the right pedicle there.
Yeah, so we have a lot of sclerosis and some thickening. So what's your diagnosis?
I'm not sure.
Okay. Okay, so this is a MR scan at L4 to the lamina. Here are CT scans. Okay, so here we can kind of, I mean, not CT scan, these are oblique plane films.
Yeah, I guess there's a fracture there at the neck of the Scotty dog right there.
Right there, right, yeah. And maybe a little thickening on the other side. And so here's the, so here's a facet joint, there's the fracture, and there's the other facet joint. And here we can see the thickening of the pars on the opposite side. So it's a stress reactive change of the opposite side due to the spondylolysis on the left.
Okay.
And here we can see the thickening on the right side, and there's the pars defect on the left side from a chronic spondylolytic defect or chronic pars fracture. Okay, Dan?
Okay. Looks like T1. That's T3.
I'm sorry, I can't hear you.
Yeah, sorry. T1, T2 sagittal. Okay, yeah, so there's some increased signal in the posterior elements there at the facet joint. No, that's pars, yeah.
Yeah, so here's another pars
Yeah.
defect.
And then
Yeah, bilateral. Okay. And here we can see another case where we have bilateral pars defects extending into the lamina. And this one crosses the midline and goes over to the other side. Okay. And then here's another defect here. Here we have bilateral pars injuries in this patient, spondylolysis. Again, pars defect. And one thing that you can see here, basically what looks like two facet joints, kind of in the same slice. One's a facet joint, one's a fracture. Pars defects. Facet joint, pars defects. And here we can see pars defects on both sides. Okay, Elior.
So here, pars defect, like 3-4. Yeah.
Yeah, it turned out it's bilateral. Okay, Robert.
All right, so we have a 51-year-old with low back pain. Here, let's see, there's a little bit, some grade 1 anterolithesis of L2 on 3 and L4 on 5.
Okay.
And I don't see any definite spondylolysis on this exam, at least, or on these cuts.
Okay. So now
Here,
these are on either side.
here, I think at L2, it looks like there's spondylolysis.
Yeah. And then here we go, spondylolisthesis, and with bilateral spondylolysis here at the 4-5 level. Okay, Tayson.
All right, so 5. So L2 has a severe impression deformity there, and it looks like some of the fragments are retropulsed into the spinal cord, narrowing it.
Right, producing some pretty severe narrowing of that central canal, and we see a lot more disease farther down. But yeah, that's severe central stenosis from the fracture.
Yeah.
Okay, Dan.
Like stir images, it looks like there could be, like some ligamentum flavum hypertrophy
Good. Yeah.
causing severe stenosis.
Yeah. Right. And then a lot of people say hypertrophy of the ligamentum flavum. A number of the surgeons that I used to work with prefer the term redundancy because they claim that if you go in there surgically, you don't actually see thickening of the ligamentum flavum. What happens is you get decreased height. The ligamentum flavum buckles on itself, and it's more the buckling of the ligamentum flavum that causes the stenosis rather than true thickening of the ligamentum flavum. So I usually call it redundancy. And then here we can see severe central stenosis. Okay, Elvira.
60-year-old female, increasing back pain and pump.
So the patient had an infusion pump to treat for chronic pain,
Mm-hmm.
and now their pain is going up.
Right, so in the central canal, there's this, this lesion, call it now T1, it's bright, on the stir it's dark. Could the catheter insert from at that level? And
Yeah, the catheter, I think we'll see the catheter. So here's that level right there.
okay,
So on 1809. Here's a CT scan. There's that level. And actually the catheter is coming down here. So what do you think might be the problem here?
is that, are we seeing a calcification at the tip
No,
of the catheter?
This is called a catheter tip granuloma.
Okay.
And it develops there over time if it's in chronically, and it obstructs the flow. So at this point, they weren't able to infuse the painkiller. So that's why their pain went up. So this is a catheter tip granuloma. It generally means the catheter has to be replaced. Okay. Robert?
All right, here, looking at the TNL spine, there's another low signal focus at L1. Some irregularity of the distal cord, kind of T10. Looks a little irregular and thick in there. But.
Yeah. Yeah, and this actually, I think we'll talk about it later. You can get adhesions where the cord can adhere to the spine, and this can tug on the spine, producing symptoms. But down here, this is actually the catheter, and you can follow the catheter coming out here.
Yeah.
And this is another catheter tip granuloma. Tayson.
All right.
The back pain case.
So it looks like we have a defect there in the posterior aspect of the cord with fluid extending into the,
Well, the cord is up here.
the spinal canal.
Okay, spinal canal, we see a little flow void there. This patient had surgery, and we can see a kind of a flow void going back here into this fluid collection. So what do you think this might be? And this patient's obviously had surgery, so there's a big post-op defect there.
Yeah, large post-op defect.
Yeah. And so this is a flow void. This is a patient with a pseudomeningocele. And this is pulsation CSF into the pseudomeningocele.
Okay.
Okay, Dan?
Okay, 52-year-old with 2 weeks post-op headache for 4 days. So we see, high signal on T2, low signal on T1. I'm assuming it's probably going to be another pseudomeningocele.
Okay,
Obviously,
right.
there might be a flow void there, maybe.
Maybe you don't always see the flow void, but this, again, obviously prior surgery, and here you can see the CSF coming out into actually the subcutaneous fat, another pseudomeningocele. Elior.
73-year-old woman, past history, breast cancer, MRM, full of white excision 2012, extramemory Paget's disease, acute embolic infarct to the left pons, 2015, treated with heparin. Okay, lower back pain. Started 10 days ago suddenly. Yeah, on T1, just low signal throughout the bones there, the vertebral bodies. The T2, just, this irregular signal. Really odd.
Post-contrast.
Contrast. Is there contrast enhancement? Maybe.
Maybe. Again, we need a...
Okay.
T1, T2, T1, post-contrast.
So if
Fat
there...
suppression.
Okay. If there is contrast enhancement, with this history, maybe I'd be worried about metastatic disease. Oh, the spinal canal. Yeah, what is that? Is there something pushing the spinal cord posteriorly there?
Here's the brain.
Yeah, so we have meningeal thickening with enhancement. So I'd be worried about kind of leptomeningeal spread or metastasis.
Right. Yeah, that's something. This patient, if we go back here, see, this is spontaneous intracranial hypotension, probably due to leakage of CSF.
Okay.
The cause of intracranial hypotension, a lot of it is unknown. Weakness of the dural sac from trauma, and then trauma. So it presents with low CSF pressure, usually due to leakage of CSF from somewhere. You can get orthostatic headache in the majority, and radiculopathy. Okay, just examples of the kind of increased CS. Okay, and then let's go out and talk a little bit about sacral fractures. You can certainly get vertical fractures, combinated fractures. Can extend over into the canal. Some people talk about zones of these. If they're vertical fractures, 1, 2, and 3, the vast majority I've seen have been in the 2 category. And then you can kind of describe the extent of the fractures and where they extend outside the bone and the amount of displacement. And if so, if it's affecting any of the nerve roots. So they have, the H type is relatively common, especially in osteoporotic people, often people who are on chemotherapy with osteoporosis, but you can get a number of different categories and you can just kind of describe them. So there are a number of different ways to, I don't really want to spend a lot of time on this. So there are different types. Again, generally, I describe them and I don't use any specific typing system. But if you get into situations where you see a lot of these or work with surgeons who operate on them, you need to find out what kind of a system they use and use a system that's locally prevalent. Okay. And obviously then the clinician will correlate the findings and the location of the fractures with the neurologic deficits and then determine where to go. So these are more clinically relevant grading systems. And then you can also look for pelvic ring instability. And their grading systems that I don't think we need to go through. Okay, so that's kind of a trauma to the spine. So let me stop here and then give me a second to load up the next lecture and then you can log back in.